Hello, everyone. My name is Olivia, and today I will be presenting my project on the effect of vitamin D and calcium on the genetic disease osteoporosis. For the sake of this course, I will be limiting my discussion to nutritional intervention via dietary means, that's to say, consumption of foods rich in said nutrients and not intravenous supplementation, nor the administration of artificial supplements such as pills. So, why did I choose this topic? Since young, we are taught to drink milk every day for the sake of our growth. As a short kid myself who wanted nothing more than to grow taller, I took this information very seriously, and rightfully so. Indeed, milk is packed with nutrients that play crucial roles in not only adolescent growth, but in maintaining strong and healthy bones to prevent bone related diseases such as osteoporosis. With the prior knowledge of the strong correlation between calcium and osteoporosis, and for me personally, a newly discovered knowledge of vitamin D's role in preventing soft and flexible bones, I formulated the following research question to better understand the benefits of consuming foods rich in both nutrients and the extent to which they, when working together, are able to prevent genetic diseases, specifically osteoporosis. I will also provide recommendations for a suitable diet as well as the appropriate lifestyle to sustain it. First and foremost, what is calcium? Calcium is a mineral, proton number 20, the periodic table. It has numerous functions, one of which is to maintain strong bones and teeth. Our bones are a storage site for two minerals, one of which is calcium. The body is not able to synthesize its own calcium, so we get this mineral by way of dietary consumption. The way that solubilized calcium is digested and absorbed into the blood is via two possible pathways: active transport or passive diffusion. The active transport of calcium occurs in the end of the duodenum, beginning of the jejunum, and requires both ATP as well as calcitriol, the active form of vitamin D3, to facilitate the transportation into the bloodstream and into the process of building bone. Now, throughout our lifetime, we are constantly replacing old and damaged bones and building new ones in what is called the bone remodeling cycle. The regulation of bone degrading and bone forming lies in the hands of two cell types, osteoblasts and osteoclasts. Osteoblasts contribute to bone formation and growth, whereas osteoclasts contribute to bone degradation by increasing their resorptive activity. You must have realized by now that every person reaches a period of optimal growth, to say. At the stage of late adolescence, our osteoblast activity no longer triumphs our osteoclast activity. That is to say, we, in layman's terms, quote unquote, can't grow taller anymore. From this point on, we don't essentially stop growing. Rather, we are undergoing constant bone remodeling at osteoblast and osteoclast activities that are closer to each other than before. As we age, enter peak bone mass, and then enter late adulthood, the osteoclast activity in our body now triumphs osteoblast activity. In women, estrogen levels also begin to drop after menopausal age. Both in conjunction lead to the relatively drastic drop in bone mass compared to men. In adults with osteoporosis, the rate at which bone mass decreases is all the more accelerated, and you will see a steeper drop in the graph. That being said, and by looking at the graph, you can pretty much get the gist of what osteoporosis is. It is a medical condition in which a person experiences low bone mass and a deterioration in bone tissue. If you take a look at the picture here, we see the difference between healthy bone tissue, shown left, and osteoporotic bone tissue, shown right. Osteoporosis affects the bone remodeling cycle we mentioned earlier, such that bones affected by the disease appear to have larger holes and are more brittle, as we can see here. This weakening of the bones puts the person at risk for fractures, commonly at the hip, wrist, or spine, with even the mildest of stress. There are inherently no symptoms in the early stages of bone loss, which is why osteoporosis is often called a silent disease. It's terrifying, really. Unless you make regular checkups at the hospital for your BMD, you really won't know if you're struck with a disease until you get older, find yourself losing height, having a stooped posture, or worse, injure yourself, possibly permanently. Sadly, osteoporosis strikes a large portion of the population. According to the CDC, low bone mass, the precursor to osteoporosis, is observed in about 50% of women ages 50 above and 30% of men in the same age pool. Osteoporosis occurs in nearly 20% of women and 44% of the men. Considering the US population, that is 54% of elderlies experiencing either or both conditions at the femur neck or spine. It's worth mentioning, however, that there is a strong genetic component to osteoporosis. Twin and family studies have shown that 50 to 85% of the variance in peak BMD is attributed to genetics. Extensive research have identified several possible candidate genes as shown on the screen. The polymorphism in the regulatory region of collagen 1 alpha, in particular, has had substantial evidence supporting its contribution to osteoporosis. Sulfide quinone reductase like protein, which functions to regulate cellular hydrogen sulfide levels, also show function in the metabolism balance in postmenopausal women. However much evidence is found, though, there have been some inconsistencies. For example, in the research on vitamin D receptors. And overall, while genetics have a great deal to do with increasing risk of osteoporosis, the exact osteoporotic pattern still remains a subject of further research. Now, let's switch gears and talk about the exact correlation between calcium, vitamin D, and osteoporosis. How exactly do they interact in the body? And how exactly does osteoporosis happen when both nutrients are deficient? The calcium consumed throughout our lifetime is regulated by the system as shown here. When we are low in blood calcium, our parathyroid glands release the parathyroid hormone, which stimulates osteoclast activity and releases calcium ions from existing bones. The parathyroid hormone also stimulates 125 dihydroxyvitamin D3 production, also known as calcitriol. Calcitriol then increases calcium reabsorption in order to get calcium levels to a desired position. When the body is experiencing high blood calcium, on the other hand, the thyroid gland releases calcitonin, which stimulates osteoblasts and stops the release of calcium ions. Calcitonin then increases calcium excretion in order to regain calcium balance. Now, without sufficient calcium, this system will not function as optimally as it should. As mentioned earlier, the human body is not able to make its own calcium and thus relies on the dietary supplementation of the mineral. Without enough calcium, the body is not able to make new bones to sustain the lifelong process of bone remodeling. In the case where more old bone is reabsorbed than new bone is created, which is observed with age, calcium balance is disrupted and bone density loss occurs. Randomized clinical trials evaluating calcium intake and bone density prove that calcium, when consumed at moderate amounts, is effective for the body. It is important to note, however, that while it is found that daily consumption of dietary calcium increases bone density, data here suggests that the numbers are too little to help in the reduction in fractures. In fact, an increase of only 0.6 to 1.8% in bone mass density was observed in the tested patients. This is to say that while calcium does help maintain bone health and prevent osteoporosis risk, it does little to treat osteoporosis should it already befall a person. This highlights the notion of prevention, not treatment. Which brings us to the next nutrient in question, vitamin D. Vitamin D, as we know, is a fat soluble vitamin. It has various functions, one of which is having a role to play in calcium regulation. Now, unlike calcium, the body is able to make its own vitamin D with sufficient exposure to sunlight, in addition to intake via dietary consumption. I won't get into so much detail, but just know that whether we source it from consuming animal products or synthesize it cutaneously, cholecalciferol, commonly known as vitamin D3, is what we're working with. Now, to get active vitamin D in the system, cholecalciferol will undergo a series of hydroxylation reactions, first in the liver and then the kidney, and you will end up with what's known as 125 dihydroxy vitamin D3, also known as calcitriol, the active form of vitamin D3, which is, again, really regulated by the parathyroid hormone. If we go to a few slides back, I mentioned how the parathyroid hormone stimulates calcitriol, which in turn increases calcium reabsorption and basically helps to restore calcium balance during times of low blood calcium. But what happens when we naturally become vitamin D deficient? With aging comes consequences. As we enter an age above 50, our osteoclast activity increases and begins to overshadow our osteoblast activity. It basically means we're breaking a lot of bone. Additionally, the 7-dehydrocholesterol in our skin, which is the precursor to cholecalciferol, decreases, which means that we can no longer synthesize vitamin D through the skin, at least not as optimally as we would younger. This reduced calcium absorption and increased osteoclast production ultimately leads to the pulling of calcium from the bone. In adults, osteoporosis may occur as a result of this. A meta-analysis investigating the effects of vitamin D on bone density and factors in postmenopausal women found that vitamin D consumption, especially with calcium, proved effective in reducing hip and non-vertebral fractures. Certainly, further research is still needed, but such is the case, we can see that it is crucial for a person to consume sufficient amounts of vitamin D in order to maximize the efficacy of their calcium absorption system, reduce bone resorption, and therefore reduce risk of bone density loss. Now, at this point, we can be confident there is evidence showing a strong correlation between calcium, vitamin D, and osteoporosis, especially when the two nutrients are consumed together at healthy amounts. A good source of dietary calcium are dairy products such as milk, yogurt, cheese, due to their high calcium content and absorption rate, as well as leafy greens. Sources of dietary vitamin D include fatty fish, egg yolks, and fortified milk. Consuming these foods regularly can help the body maintain positive calcium balance. Ideally, the RDA recommends the consumption of at least 1,000 milligrams of calcium daily for adults and at least 600 IU or 15 micrograms of vitamin D per day. Additionally, research suggests that foods rich in lesser nutrients such as vitamin K and zinc prove beneficial in supporting metabolic processes of the bone and improving the overall efficacy of the two major nutrients, calcium and vitamin D. I believe this is a good extension to this research topic, should it be of interest to you. Now, the takeaway from this presentation is, overall, the best way to prevent osteoporosis is to begin efforts early in adolescence. Optimal consumption of calcium and vitamin D should be supported by a healthy lifestyle of limited alcohol and caffeine consumption, avoidance of smoking, as well as involvement in consistent weight bearing and strength training exercises. Compliance is key here, and I recommend that such habits be practiced throughout the life cycle, with emphasis during the age of increased rates of bone loss. Thank you.